So the next question is, a patient with previously well-controlled diabetes managed with metformin is stated on prednisolone 40 for GCA. So because of the steroids intake, now the patient has blood glucose levels 7 to 9, but they rise to 15 to 24 before lunch and dinner. So what is the most appropriate management? So isofane insulin in the morning. So this is rapid acting isofane insulin in the morning, and you're going to give this insulin. Okay. So insulin glargine once in the 24 hours, intermediate, definitely not. And act rapid 3 times. This is also going to cause hypo. So isofane is the most appropriate insulin given in this case. Yes, intermediate one. Yes. So these are the anti-diabetic drugs that are the metformin, sulfonylurea, DPP-4, and Sagla-2, the SGL2, and then the thiazolidinediones and the alpha-glucosidase inhibitors or the oral GLP-1. So all of these are the important anti-diabetic drugs. And what are the indications and contraindications of giving these? Sulfonylurea are going to cause hypoglycemia, so we are never going to give hypoglycemic episodic patient to sulfonylurea. Metformin is the first line and it is really given to every patient. Then the DPP-4, you're never going to give the patient who has some type of renal problems or the pancreatitis. Okay. Then the SGL2, very excellent choice for the heart disease. Like if there is any CVS risk or the CKD risk, then we are going to choose SGL2. So if there is high BMI, obese patients, then we can also give the oral GLP-1, that is oral semaglutide. So this is the isofane insulin, protofane. Again, this question was exact given in the question in today's recall. So look at this question. A patient receiving treatment for GCA being received. The treatment consists of 40 mg prednisolone, the exact same question. Prior to prednisolone, the patient had responsible glycemic control ranging from 6 to 10. But now he is at 15 to 24. So what is the most appropriate regimen for the management of the blood glucose levels in an inpatient? So isofane insulin, which is protofane. C. Intermediate acting, isofane insulin, protofane. So whenever the patient is inpatient, you are going to give isofane. So this is another question regarding the choice of the anti-diabetics. 58-year-old woman presents to GP clinic for review of her type 2 diabetes. She was diagnosed with diabetes 8 years ago and has been taking metformin for the 5 years. 4 months ago, linagliptin was added. Her medical history includes hypertension, dyslipidemia, and now on examination she appears well. Body BMI is 29, CVS risk is unremarkable. Now the HbA1c is 7.4. Estimated GFR is 75, and urine albumin creatinine ratio is 2.5. So which of the following is the most appropriate next step? So cease Lina and commence EMPA. Why? Because DPP-4 should be discontinued if they fail to reduce. Like it was 7.6 and now it is 7.4. So there is no reduction in the HbA1c. So you should just stop this medication and you can start the SGL2, the second line drug. So another question that came today, 78-year-old man is admitted to the intensive ICU with severe pneumonia requiring intubation and mechanical ventilation. No previous history of diabetes. Blood glucose levels remain 18 to 19 on repeated measurements. What is the most appropriate next step in the management? Okay. So the glucose level is 18 to 19. You will start a variable rate IV insulin infusion with frequent glucose monitoring. You have to lower down the hyperglycemia going on. This question. So we have started the linagliptin. Okay. The linagliptin at the time HbA1c was 7.6. Do you see this 7.6? And now after like few months, like now it is 7.4. Okay. So 4 months before it was commenced, and now after 4 months, it is also not reducing up to a certain level. 7.6, only 7.4. Like this is a very less reduction. So because of the failure of the response to the linagliptin, we are changing the medication. Okay. So if in 3 to 6 months there is no response, then you can just discontinue the DPP4. Okay. So another question that says a 2-year-old boy is brought by his parents because of the difficulty with toilet training and passes soft stool twice daily without pain or straining. Whenever he feels the urge to defecate, he crosses his legs, runs behind the sofa, and passes stool there. His growth and development are normal and physical examination is unremarkable but is the most appropriate management. So you will temporarily stop the toilet training and restart after several weeks because now the patient, child is in stress. Okay, he cannot pass the stools and he might have the constipation then if he is not properly defecating in this way. So we have to stop the toilet training because the patient is in stress now and then we can restart it after several weeks. So toilet training refusal, what are you going to do? You're going to stop the toilet training, then advise the parents to stop all toilet training attempts for 1 to 3 months, then remove the pressure, criticism, and punishment. Then reintroduce the toilet training when the child is ready. Okay, so that's all. So the next question for today, like this question also came in my no. This I had one question in my exam as well. It is that was the secondary angiogenesis, no, the primary angiogenesis problem with the patient. Okay, and the answer was positive enforcement. I had such question in my exam as well. So a 2.5-year-old child is undergoing toilet training and the child passes soft stools once or twice daily without pain or straining. Whenever the urge to defecate occurs, the child crosses the legs, hides behind the sofa, and passes stool there. Physical examination is normal, but is the most appropriate management. So the most appropriate management is you have to positive reinforce the child. Then the 72-year-old man presents with lesion on the dorsum of his hand that has enlarged gradually over several months. The lesion is crusted, hyperkeratotic, and irregularly colored. The surrounding skin shows marked sun damage with multiple actinic keratosis. And there is a slow rise in the size. What do you guys think? If the carcinoma is rapidly rising, then it can be referred to as keratocanthoma, okay, within few weeks. But the slow rising size is squamous cell carcinoma. Okay. So the slow rise will be squamous cell carcinoma having the sun exposed area, hyperkeratotic and irregularly colored. All the lesions, all the features of the carcinoma. Okay, so this is the management regarding carcinoma, that the choice of treatment is depends on the lesion, factors, and the patient. Then there may be cryotherapy, curettage, and the cautery. Poor wound area, healing area can have the photodynamic therapy, and if it is in situ, then you can even try the 5-fluorouracil or the imiquimod cream. So this is one of the picture taken from the therapeutic guideline, and then you can even do the follow-up as well. So this is keratocanthoma. You have to see the growth. So this growth can be within the month, within the weeks. Because BCC have several pearly lesion, like the pearly lesion having the telangiectasias, rolled edges, indurated base, like in this way. But squamous cell carcinoma have the hyperkeratotic plugs written in the question. Okay. So 68-year-old man presents with painful ulcerated exophatic nodular lesion on his left forearm. It has been progressively increasing in size for the last 2 years and is painful and does spontaneous bleed. He lives in a remote area for the Northern Territory with few medical resources, works as farmer. Okay, works as farmer, straight away a very high risk for the squamous cell carcinoma or the BCC to develop. On examination, blood pressure is okay, temperature is okay, and then apart from lesion on his arm, the rest of the physical examination is unremarkable. PCR is uh, 1S2404 for the biopsy of the lesion is negative. Okay. So this is the lesion, and which of the following is the most likely diagnosis? This is squamous cell carcinoma. Look at the picture. So a 63-year-old man presents to GP clinic with 3-month history of the gradually enlarging horn-like growth on the right side of his face. Works as a farmer and spends most of the time outdoors. He has history of multiple actinic keratosis treated with cryotherapy. He takes no regular medications. On examination, he appears well with vital signs and normal limits. There is 2 centimeter keratotic projection with an erythematous base on the right side of his face. Okay, so look at the lesion. What is the following is the most appropriate management? So surgical excision with margins. Because the cutaneous horns require biopsy to exclude underlying malignancy, particularly in the elderly patients. Squamous cell carcinoma is found up to 40% of the cutaneous horns, especially in the sun-exposed areas. This is today's question, doctor. Complete excision with histological margin assessment is the preferred management for the cutaneous horns. So the same SCC treatment, and then the next question says a 56 years old woman presents with a 3-month history of progressively shoulder pain and stiffness. Examination show marked restriction of both active and passive movements, particularly external rotation and adduction. Plain short shoulder X-ray is normal. She has already completed a course of physiotherapy and received an intra-articular corticosteroid injection with minimal improvement. So what is the most appropriate next step? Now you will do the ultrasound guided hydrodilatation of the glenohumeral joint. What do you guys think? This is the aggressive treatment step. Okay, yes, adhesive capsulitis or the frozen shoulder. So what are the clinical features? Gradual onset of the shoulder pain and stiffness, progressive loss of active and passive range of movement. Pain is often worse at night and normal X-ray. Okay, so these are the stages that there will be painful freezing, then the stiff frozen shoulder which is not moving, there is marked restriction, and then the recovery with the gradual return of the range of movement. So what is the management algorithm? You will do the education and the simple analgesia with the physiotherapy as well. If inadequate response, then you can continue the physiotherapy and consider intraarticular injection. So up till now, the patient has done all the management steps, but now if the patient is still having the symptoms that are persistent, then you can consider the hydrodilatation, that is distension arthrography. Hydrodilatation, injecting a saline with corticosteroid to stretch the joint capsule and improve the range of movement. So the friction is like being reduced by giving the hydrodilatation, having the injecting saline and corticosteroids inside it. Okay, so we had like we just read the guidelines and then we use the AI to make all of these flowcharts. Like I give all the information to the AI and then I make these flowcharts myself. Okay. Like we have been working since the morning today, and we have been gathering the questions and single question, then we will be reading the articles, and then we will be finding the answers, and then the focus areas from the guidelines, and then we will be collecting all this information, collecting it and gathering in a single flow chart, and then pasting it under the question. So in this way, thank you so much, everyone, whosoever is appreciating. Thank you so much. So the refractory cases after 3 to 6 months above, consider the referral to the orthopedic specialist for the further options. Manipulation under anesthesia and arthroscopic capsular release. So the hydrodilatation was in today's question. Consider the hydrodilatation, okay? Because the patient had this initial management, then this one as well. Now the patient was not improving, so you can consider the hydrodilatation. So rotator cuff tear, subacromial bursitis, and the adhesive capsulitis, AMC favorite topics. So we can just quickly go through what are these. If you have diabetes mellitus, then there is a risk of adhesive capsulitis to occur. Then there is insidious, gradual over weeks, months onset. Then there is diffuse shoulder pain at rest at night. Both active and passive range of movement are decreased. So this is the main difference because rotator cuff tear has active form, active range of movement limited, but the passive is okay. Similarly, subacromial, the passive is okay. Okay. But in adhesive capsulitis, passive is also compromised, active is also compromised. Okay. So the empty can test, is that written in this? Yes, the empty can test. This is again another AMCT call. The empty can test positive, drop arm test positive, and the empty can test positive in the rotator cuff tear. But the capsular pattern like this, there is no test for the adhesive capsulitis, and the Hawkins-Neddy test for the subacromial bursitis. Okay, so 63 years old woman presents to GP clinic with a 4 months history of worsening right shoulder pain, especially at night. She remembers injuring her shoulder about 5 months ago and when she had knocked it on the kitchen shelf, after which she had some trouble reaching above her head. So the overhead movement is causing pain. About a month ago, this began to worsen and they continued ever since. Medical condition, there is diabetes, a risk factor, and then on examination, restricted range of movement in active and passive. So both of them are compromised, straight away adhesive capsulitis. So a 72-year-old man presents to GP clinic with a 3 month history of left shoulder pain and stiffness. The pain is worse at night and all shoulder movements are restricted. He is right-handed and can go no longer play bowels due to these symptoms. Okay, so he has type 2 diabetes, hypertension, medication include metformin and rodipine, and then he does not smoke and drink. On examination, he appears well with vital signs in normal limits. There is a marked reduction in the both active and passive. So both active and passive, and the empty can for the rotator cuff is negative. Okay. So what do you guys think? History of diabetes causing the adhesive capsulitis. Yes. Another question for today that says a 42-year-old woman presents with recurrent episodes of severe headache, palpitations, and profuse sweating. Each episode lasts approximately 20 to 30 minutes and resolves spontaneously. Her blood pressure and over vital signs are normal between the episodes. Which of the following is the most appropriate initial investigation? So, what do you guys think? Okay, there is headache, there is palpitations, yes, and the profuse sweating. Then the pheochromocytoma. And pheochromocytoma, what is the investigation of choice? What is the investigation of choice? No, MRI adrenals is a further investigation, right? But the first one, initial investigation. Yes, urine metanephrines, very good. So this is the treatment of the pheochromocytoma.